topic of lecture is historical stages of therapeutic dentistry, its chapters, the value of scientific research of Ukrainian scientists, dental instruments, pathological and clinical anatomy of the teeth, dental charting, science of teeth. This lecture outlines historical stages of dentistry, its chapters, dental instruments, their use, histological, clinical, and anatomical features of the teeth, science of teeth, dental charting, concept of ergonomics in dentistry. Dentistry, it is the branch of medicine that is involved in the diagnosis, prevention, and surgical or non-surgical treatment of diseases, disorders, and conditions of the oral cavity, maxillofacial area, and the adjacent associated structures and their impact on the human body. This is the definition of dentistry, actually what dentistry deals with. Dentistry has a long and fascinating history. From the earliest times, human beings have been plagued by dental diseases. Many of the remarkable techniques used in modern dentistry can be traced to the very earliest of times in every culture. Let's go through this history of dentistry development. This diagram just gives you the main cornerstones in dentistry. We can trace dentist some data that is related to dentistry from earliest times. Here you have this years 980, 1037. Iran, Uzbekistan physician and philosopher Ibn Sina or Avicenna describes medical knowledge of the time and covers dental diseases and treatment as well of them. His writings influenced European medical ideas throughout the Middle Ages. Later we jump into France. So dentist Pierre Fauchard, he considered to be father of modern dentistry, and his book, The Surgeon Dentist or Treatise on the Teeth, was major professional medical event at that time. He also opposes the contemporary belief in tooth worms as a cause of caries. And actually, at that period of time, there was such concept that tooth worms exist and they cause tooth decay. Next, we jump to the Germany. The American scientist Miller established the microbial basis of dental decay. Pay attention to the date when microbial concept of tooth decay was suggested, and initiates discussion of what was to become the focal infection. Debate with his description of bacteria in the dental pulp. The next cornerstone in modern dentistry is considered to be such person as Green Vardiman Black, United States of America. He publishes his monumental 2-volume treatise Operative Dentistry. It was a great event at that time. And this remains the essential clinical dental textbook for 50 years. And still, we use the concepts of Green Vardiman Black in caries cavity preparation, and we use his Black classification of caries cavities nowadays. After that, we move into Germany and USA's collaboration, USA and Germany. So the company Ritter presents a dental unit combining drill, pressurized water, air, cauterization, and light, something that resembles modern dental unit. Other companies follow and standards for dental surgery equipment are established. Before that, there was mm, old-fashioned dental units that were driven by foots or by hands. It was just a separate chair and a separate handpiece. Light was separately, but for that time, 1919, the first uh, modern dental unit was designed. The next, it is United States of America, USA. Company Dentsply and year 1957 introduced the ultrasonic scaler. 1960s, sit-down four-handed dentistry was developed, with the patient lying almost down, and from that time it becomes popular. This technique improves productivity and shortens treatment time. In 1960s, Europe, lasers were developed and approved for soft tissue procedures. After that, we moved back to USA, and there was introduced tooth colored restorative material, plus increased usage of bleaching, veneers, and implants, and all of that give the rise to era of aesthetic dentistry. So from this time, 1960, we can start talk about aesthetic dentistry development. 1965, Germany, the first micromotor handpiece, slow-speed handpiece was presented by company Siemens, and at that time, the era of Doriot arm finished. In 1975, again Germany, it presents articaine, anesthetic, active ingredient of anesthetic, articaine, and from that time it is introduced as a standard substance for local anesthesia. It is very efficient, it is not toxic, and for now it's considered to be the gold standard in local anesthesia in dentistry as an active ingredient. So this diagram just gives you short understanding, the main key points of dental history in the world, so-called milestone in dentistry. Of course, there were a lot of intermediate steps, but here I just focused on the most important. The next chapters that this lecture outlines goes about definition of therapeutic dentistry and its structure and what does it study. So therapeutic dentistry or dental therapy, it is a part of dentistry that studies reasons and mechanisms of these diseases, periodontium tissues diseases and oral mucosa diseases, diagnosis, treatment, and prevention of all of that. Dental therapy or therapeutic dentistry includes such chapters: propedeutic course, preventive dentistry and endodontology, periodontology, oral pathology. Oral pathology, of course, deals with oral mucosa diseases. Propedeutic course. This that you are studying right now on a propedeutic course of dental therapy, it deals with the history of dentistry. It studies the anatomical and physiological features of the oral cavity, dental instruments, dental office equipment, ergonomics issues, ethics, and deontology. And of course, some questions about structure of Ukraine dental service we will discuss. Preventive dentistry and endodontics. It is a branch of dentistry that deals with the prevention, diagnosis, and treatment of the diseases affecting dental pulp, root, and periapical tissues. Restoring a tooth portion affected by dental caries, root canal treatment of the tooth whose dental pulp is infected, and so on, are some of the commonly performed treatment procedures in endodontics. So, periodontics or periodontology. It is a specialty of dentistry that studies supporting structures of teeth, diseases of them, and conditions that affect them. Oral pathology is a specialty of dentistry which deals with the reasons, identification, and management of diseases affecting the oral and maxillofacial regions. And these photos just show you some of the oral mucosa disorders. We have finished with the chapter about structure of dental therapy and definition of this of these chapters. And now we move to instruments, so basic instruments that are used in dentistry, especially dental therapy. So there are a few basic instruments that are universal to almost every procedure in dentistry, and here they are shown. Instruments can be classified in two broad categories: hand instruments, rotary instruments. Hand instruments are for teeth examination, for cavity preparation, for material placement and material mixing. Rotary instruments, it is hand pieces and attachments to hand pieces. Hand pieces can be slow speed, high speed. Hand instruments has their structure, so-called anatomy. Hand instruments have handle and working ends. It can be double-ended, and as in this way, only working part on the one end of the instrument. So working ends are here. Here we have shanks, handles. Okay. So working ends, it is functional parts of the instruments. They can have a variety of functions, including cutting, packing, carving, placing, and condensing. They are adapted to the function of the particular instrument, may be beveled. It means that working end is cut at an angle. An instrument can be single-ended, one working end, or double-ended, two working ends. Shank of the instrument. It is part between working end and handle. It can be straight or angled. The function of the instrument determines the angle and flexibility of the shank. Handle of the instrument, it is the part of the instrument that the operator grasps. Design is related to the function of the instrument. So it is structure of hand instruments. We start from examination set of instruments. The first one, it is mouse mirror. It has such functions. The first one, to provide indirect vision, to reflect light, and for retraction and protection of oral tissues, and one more for magnification of the vision. The number of the mirror represents size of mirror head. Dental probe. So this instrument is is used for detection of defective pits and fissures, calculus, deficient margins of restorations, crowns and bridges, carriers, examination of tooth surface, pointed teeth allows good tactile sensitivity. There are a number of varieties. It can be single-ended or double-ended. Different styles are available. Working ends may vary. It can be straight, as in this case, or curved or hooked, as in this case. Periodontal probe. It is specially designed instrument that is used to measure the depth of periodontal pockets. Tip is blunt and it is small. It looks like a small ball on the end. And this reduces possibility of tissue trauma. Its working end is calibrated in millimeters, and that's why it gives possibility to measure the depth of periodontal pocket. This size of these millimeters can be different, but if it is standard World Health Organization probe, the size, the length of this calibrated part, black or white, usually is 3 millimeter. So every part is 3 millimeter. That's why it is easy to measure the depth of periodontal pockets. Varieties. It can be single-ended or double-ended. It can be straight, curved, or at right angles. Sometimes plastic types are available. Tweezers as well belong to examination set of instruments. This instrument has a function of placing small objects in the mouth and retrieving small objects from the mouth. Locking type, lock to prevent dropping materials. That's why we use this instrument to pick up small objects, burrs, for example, paper discs or rubber cups, to pick up something, or to pick up and put into the oral cavity cotton rolls. Varieties can be such: locking or non-locking types. Working ends can be straight, curved, as in this case, serrated or smooth. Another set of instruments that is used for basic restorative procedures, and the first one is spoon excavator. Pay attention to the working ends of this instrument. It has a working end in the form of small spoon. This spoon is sharp enough to cut necrotic, decayed dentine from the carier's cavity. So, functions of spoon excavators. A spoon-shaped working end is used for spooning out dentinal caries from the cavity preparation. Edges of working end are sharp. Any remaining caries will be removed with a conventional handpiece and a round burr. Sizes of this instrument as well is different. Size depends from the cavity this excavator is used for cavity preparation. For small cavities, small size of instruments available. For medium depth cavity, medium size of instruments. And for big cavities, bigger sizes of instruments. That's why it is available as well in different sizes. So the spoon excavator, it was instrument for cavity preparation. Instrument for cavity preparation. And now we move on with instruments that are used for restoration of caries cavities. And the first one, it is flat plastic instrument. Flat plastic instrument. Or ball-ended instrument. Or plastic instrument. Ball-ended because it has a ball on another end of the instrument, and here it is flat. So functions of this instrument: to deliver materials to the cavity preparation, to remove excess materials, and to shape filling, to give to it anatomical grooves, fissures. So actually that is the task of this material, of this instrument, to take restorative material and put into the caries cavity and shape it. Varieties. Different sizes and shapes available. It can be single-ended or double-ended. It can be combined instrument. It means that on one side it is flat plastic instrument and on another it is ball-ended instrument. Round-ended plastic, it as well called, or ball-ended plastic. The functions of this part of the instrument, ball-ended, but on this case it is not ball, it's like a cone or cylinder or like a rugby ball, but different shapes available. It depends from the manufacturer and from task this instrument should do. So this round-ended or ball-ended plastic is used to create anatomical shapes in composite material during restorations. The ball-ended plastic instrument can also be used to pack and condense composite materials. And the last one, instrument that is used for restoration purpose, is spatula, mixing spatula. It has such functions: to mix dental materials. The only peculiarity that this instrument can be done from metal or plastic. Metal spatulas are used mainly to mix cements. Anodized aluminum spatula will not stick to any composite materials or discolor materials. Plastic spatulas are used to mix composite materials, as metal can stain composite material. Next group of instruments that is discussed on this lecture is rotary instruments. Here it goes about hand pieces and attachments to them, burrs or cups or paper discs or whatever that is attachment to handpiece. But mainly we talk today at this lecture about burrs. So dental handpieces and rotary attachments help to make dental treatment more comfortable for the patient and reduce the amount of time needed to complete procedures. The first one, the most widely used, it is air turbine handpiece. It also called fast handpiece, high-speed handpiece, air rotor handpiece. All of that are synonyms and can be used synonymously, one instead another. Types are contra-angled, as this one, and the function of contra-angle air turbine handpiece or high-speed handpiece is to remove of tooth tissue during restorations and preparation of teeth for fixed prosthetic appliances. So cavity preparation, that is the task of this instrument. As well, it is used for polishing of restorations together with special polishing burrs, and high speeds create heat and friction. That's why handpiece must be run with water to cool the tooth and to prevent pulpal damage. High speed saves treatment time and reduces vibration, so it is comfortable for the patient. High-speed handpieces is driven by turbine, may need to be lubricated. Of course, prior to use any of device, necessary to learn very carefully, read and learn manufacturer's instructions. Compressed air rotates the turbine, which then rotates the burr. So they need air compressors. Speed. Speed of these high-speed handpieces can be up to 500,000 revolutions per minute. They accept friction grip attachments, so please memorize these friction grip attachments. And they are attached, handpieces attached to dental units. Varieties of handpieces. Can be different. With or without light, with a smaller heads for difficult access. Usually such handpieces demands special burr-changing instrument, but modern types of handpieces do not demand special burr-changing instrument. They have button on their head, and dentist just press on the button that is located on the head of the instrument. Actually, here it is the head of the handpiece, and it is handle. Head, handle. Another instrument, it is slow speed handpiece. On this photo is shown straight handpiece. This type of handpiece is used in surgical procedures to remove bone. It cannot use air to, in this case, surgical procedures, dentist cannot use air turbine, as the water is not sterile that come from the handpiece. That's why such slow speed handpieces is used for surgical procedures. Another option where this instrument can be used in extraorally chairside or in the dental laboratory, for example, for denture adjustments. The speed can be up to 40,000 revolutions per minute. So here it is handpiece, and here it is micromotor to which this handpiece is attached. This type of handpieces accepts long shank attachments, and they are attached to electric motor that fits into the base of the handpiece. Base of the handpiece and electric motor, micromotor. Contra-angled slow speed handpiece. Contra-angled. The function of this instrument is to remove tooth decay, together with special burrs. As well, this handpiece can be used for polishing of restorations, polishing of teeth, oral hygiene procedures, and procedures that require torque, and of course refine cavity preparations and adjust occlusion after restoration. They are driven by gears and speed. Similar to the straight handpiece, it ranges from 0 up to 40,000 revolutions per minute. Attachment is electric motor that fits into the base of the handpiece. Okay, and now it's burrs, attachments to the handpieces. So burrs. There are great variety of burrs. They have classification, special classification that we will discuss, but at the beginning I suggest to go through structure of the burr. So the burrs have head, neck, and shank. Head of the burr is a working end. Function depends on the size and shape of the head. Many different sizes and shapes, each used for a different function, cutting, polishing, or finishing purposes. Neck. It is the part that connects the head to the shank, usually narrows towards the head. Shank. It is the part that fits into the handpiece. Shapes and lengths vary depending on function. Can sometimes be marked to identify burr type. On the neck can be stripes or colored bands. Classification of burrs according to shape. Shape determines function. The examples that follow relate to tungsten carbide burrs. Rose head is used for cutting and removing tooth decay. Pear-shaped Unfortunately, I'm not sure if here we have pear shape. Okay, it can be some cylinder, for example. So is used for cavity preparation and for shaping walls. Fissure. Different types of fissure burr. Fissure burr, tapered fissure. All of them is used to shape and prepare the cavity preparation. Some is used for finishing and polishing of buccal wall of caries cavity of restoration, buccal wall of restoration, especially cervical part of the tooth crown. How to recognize burrs that fits into high speed and slow speed. So to recognize them, we need to look at the grip of the instrument. So this is grip for slow speed, burr, latch type shank, and this is grip for high speed, friction grip shank. So latch type, friction grip shank, latch type, and friction grip. So grip refers to the way the burr's shank is gripped into the handpiece. Composition refers to the head of the burr and what it is made from. Generally, most ledge grip burrs are made of steel. Most friction grip burrs are made of tungsten carbide or diamond. Here it is diamond, and here it is steel on the working end. Most long shank burrs are made from steel if they are meant for surgical procedures, and stainless steel if they are meant for laboratory procedures. And I will return back to this slide to show you actually standard shanked burr and long shanked burr that possibly can be used for surgical procedures or for some areas where access is complicated. That's why it is necessary to have long shanked burr. So standard shanked burr, pay attention to the lengths. And here, pay attention to the lengths. Okay. Some points to remember about rotary attachments and burrs. Most often called burrs, but also available are wheels, discs, rubber points, rubber cups, and stones. Each has a particular function: cutting, polishing, finishing, or caries removal. They are made from various materials: tungsten carbide, diamond, and steel. They can have flutes on the cutting edges. The end of the shank determines which handpiece the attachment will fit into. Long, straight shank for straight handpiece. Ledge grip for conventional type or slow-speed handpiece. Friction grip shank for air turbine handpiece or high-speed handpiece. Other various attachments such as snap or screw type attachments can fit into conventional type or slow-speed handpiece. We have finished with instruments, and another question that should be discussed, it is anatomical and histological features of teeth. In adult humans, there are 32 permanent teeth. These are preceded during childhood by 20 deciduous teeth. The tooth lies in a bony socket. The alveolus that is covered an oral mucosa called the gingival gums. And actually here you have this schematic diagram where can be seen temporary teeth and deciduous teeth and permanent teeth in follicles. The tooth has such structure. It covers in the crown part by enamel, in a root area, dentine covers by cementum. The main part of the tooth is dentine. It is in root area and in crown area. In crown area, it is covered by enamel. The inner portion of the tooth is pulp, dental pulp. Cementum that covers dentine in the root area is connected to the bone by periodontal ligament fibers. Here we have gingival crevice and cemento-enamel junction. It is that place where enamel cross into cementum, where they meet together. Every follicle has its stages of development, and in a very short manner, just to refresh your knowledge, we have such stages of tooth development. Bud stage, it is 8 weeks of intrauterine life. Cup stage, 12 week of intrauterine life. Bell stage, 14 weeks of intrauterine life. And apposition and calcification, the final formation of follicle. And in a detail about every tissue that forms the tooth. So the first and the most hardest, it is enamel. Enamel is a highly mineralized and is the hardest tissue in the body. Enamel covers the anatomical crown of the tooth and varies in thickness. It is semi-translucent and its color can vary from bluish-white to hues of yellow. Chemical composition of enamel. It consists of 96-97% inorganic material by weight, the main inorganic component being hydroxyapatite, 1% organic material by weight, the main organic component being protein and 2-3% water by weight. Enamel is made up of millions of enamel prisms or rods, which run from the amelodentinal junction to the enamel surface. Each prism is made up of a large number of enamel prism has head, tail, and prism sheet, and of course interprismatic substance. Dentine forms the bulk of the tooth. It is mineralized tissue. It underlies the enamel in the crown area and is covered by the cementum in the root area. Dentine is pale yellow in color and is harder than bone and cementum, but not as hard as enamel. Chemical composition of dentine. So dentine consists of 70% inorganic material by weight, of which the main inorganic component is hydroxyapatite. Organic material constitutes 20% by weight. The main organic component is collagen fibers embedded in amorphous ground substance. The remaining 10% by weight is water. Dentine consists of many dentinal tubules that run parallel to each other, following a double curved course, and extend from the pulp to the amelodentinal junction. Each dentinal tubule contains an odontoblast process surrounded by intercellular ground substance composed of fine collagenous fibrils. The odontoblast cells are a layer of closely arranged cells on the pulpal surface of the dentine, with their nuclei situated at the basal pulpal end of each cell. Dentine is a living tissue, and with age, more dentine continues to form slowly. This dentine is termed secondary dentine. Secondary dentine is laid down at the pulpal end of the primary dentine. As a result of this, the pulp chamber reduces in size with age. Peritubular dentine tends to increase with age, reducing the diameter of the dentinal tubules. The tubules may also become completely obliterated, and when this happens, the dentine becomes more translucent. This is termed translucent or sclerotic dentine. Reparative dentine or irregular secondary dentine is laid down on the pulpal surface of the dentine in response to an external stimulus, for example, caries, cavity preparation, or excessive tooth wear. Following a severe stimulus, the odontoblast processes may be destroyed and the contents of the tubule then necrose, leaving the dentinal tubule empty, and this is termed a dead tract. Cementum is a pale yellow calcified tissue covering the root dentine. It is softer than dentine and can easily be worn away, resulting in exposure of the dentine. Its thickness varies according to location. It is thickest towards the apical third of the root and thinnest cervically. The chemical composition of cementum is such. It consists of 65% by weight inorganic, mainly hydroxyapatite component, and 23% organic component, mainly collagen, and 12% water. Dental pulp. It is soft, vascular, connective tissue occupying the center of the tooth. The shape of the pulp approximately follows the shape of the outer surface of the tooth. The pulp is made up of a pulp chamber in the crown and root canals, extending the length of the root. The shape and number of root canals can vary considerably. At the apex of each root is a foramen or foramina, through which blood vessels, nerves, and lymphatics pass. Small projections of the pulp are found under each cusp. These are known as pulp horns or cornea. The shape and form of pulp chamber. Pulp, taking into account that pulp is a soft vascular connective tissue that occupies the center of the tooth, the shape of the pulp approximately follows the shape of the outer surface of the tooth. The pulp is made up of a pulp chamber in the crown and root canals, extending the length of the root. The shape and number of root canals can vary considerably. At the apex of each root is a foramina through which blood vessels or lymphatics pass. And small projections can be found under every cusp over here. And due to age, the size of pulp chamber is reduced due to formation of secondary irregular dentine. Pulp has such functions. Protective function. It mobilizes defense cells when bacteria enter it. Reparative function. The pulp responds to insults, bacterial, iatrogenic, and traumatic. In the case of restorative techniques, with an inflammatory process, nutritive function, it provides nutrients to the odontoblasts. Sensory function, the pulp responds to injury with pain. It is one of the most important functions of the pulp. Dentinogenic function, odontoblasts are responsible for dentine formation and can generate a process of collagen fiber mineralization from the predentine. And of course, cells proliferating in the pulpal tissue create pressure, and this is thought to play a part in tooth eruption. Periodontal ligament is a specialized fibrous connective tissue that surrounds the root area of the tooth. It consists mainly of collagenous fibers. It has the following functions. It provides a support mechanism for the tooth. It cushions teeth against excessive occlusal forces, preventing damage to the blood vessels and nerves at the root apex. It maintains the functional position of a tooth by keeping the teeth in contact and prevents the tooth from drifting or tilting. The periodontal fibers undergo continuous change. Its cells form, maintain, and repair the alveolar bone and cementum. Sensors in the periodontal ligament provide proprioceptive input, detecting pressures on the tooth. So it acts as a sensor organ. And periodontal ligament has a rich supply of blood, which provides nutrients to the cementoblast. And this is a diagram that shows variety of periodontal fibers. They can be transeptal, dentinogingival, circumferential, alveolar crest, horizontal, interradicular, oblique, apical. So this is periodontal ligament and how it surrounds the cementum, the root of the tooth, and keeps it inside the alveolar pocket, preventing from drifting or tilting, and as well acts as a sensor organ. That's why the teeth cannot be cracked during mastication. What is periodontium? Periodontium, it is complex of tissues that surrounds a root of the tooth. It encompasses gingiva, bone, cementum, and periodontal ligament. Let's revise some information about saliva. Saliva is important to talk about it because it is such environment in which teeth and other organs of oral cavity stay for a long time. And composition, quality of saliva, amount of saliva directly represents the health of the oral cavity. And that's why this is necessary to know normal ranges of saliva secretion, because from it depends if the saliva can normally maintain its function. So secretion of saliva ranges from 500 milliliters to 2 liters daily production. Saliva contributes to the digestion of food and to the maintenance of oral hygiene. Without normal salivary function, the frequency of dental caries, gum disease, gingivitis, and other oral problems increases significantly. Saliva has such functions: remineralization function due to presence of calcium and phosphate ions, cleansing function due to appropriate amount of it. Normal flow rate and daily production should be from 5 milliliters to 2 liters. And buffering capacity. So such buffers as bicarbonate and phosphate buffers prevents from tooth decay progression. It buffers acids. And always try to keep pH in neutral position. So this three function prevents from tooth decay. As well, saliva has lubrication function because it helps in articulation due to proline-rich glycoprotein and mucins. At the same time, saliva acts as a digestive substance due to amylase, alpha amylase. Initial break of starches begin in oral cavity due to alpha amylase. Saliva responds for taste sensation due to such component as zinc. Bolus formation, another function that helps to form a bowl of food and easy to swallow it easily due to mucins. And of course, do not forget about lysozyme, immunoglobulins, histatins, and lactoferrins. They act as a protective substances in oral liquid. You can look at this diagram and pay attention to the functions of saliva for teeth, for food, and for microorganisms, and pay attention to the components that is responsible to maintain this function correctly. So I suggest to keep in mind always this photo whenever it goes about functions of saliva. Saliva is produced in salivary glands. What is saliva? What is the composition of it? Actually, saliva is 98% water, but it contains many important substances, including electrolytes, mucus, antibacterial compounds, and various enzymes. The digestive function of saliva includes moistening food and helping to create a food bolus, so it can be swallowed easily. Saliva contains enzyme amylase that breaks some starches down into maltose and dextrin. Thus, digestion of food occurs within the mouth even before food reaches the stomach. And just to refresh your knowledge, here I put this photo of salivary glands, major salivary glands. Parotid gland, the biggest one, submandibular gland, sublingual gland, and parotid ductus, Stenson duct. We always come across such term, oral fluid. Of course, we can use oral fluid or we can use saliva. We can use these two terms synonymously. But what is oral fluid and what is saliva? We need to clarify. So, oral fluid, it is liquid present in the oral cavity. Oral fluid is a mixture of saliva and oral mucosal transudate. For opposite, saliva is a pure secretion of salivary glands. Oral mucosal transudate enters the mouth by crossing the buccal mucosa from the capillaries. Oral fluids contain both pathogens and antibodies. It can contain remnants of food as well. But saliva is a pure secretion of salivary glands. But we can use them one instead of another. So the next chapter that we are discussing, it is structure of teeth. We have primary teeth and we have permanent teeth. Primary teeth has such group of teeth. Upper central incisor, upper lateral incisor, canine, first molar, second molar. Lower central incisor, lower lateral incisor, canine, first molar, second molar. Permanent teeth has such groups. Upper central incisor, upper lateral incisor, canine, first premolar, pay attention, we have group of premolar, second premolar, first molar, second molar, third molar. The same for the mandible. Instead of upper, we call it lower or mandible. Maxilla or mandible, upper, lower. But I'm focusing your attention at the group of premolar. Anatomy of teeth. Structure of teeth. If it goes about teeth, to recognize them, to give correctly names to the surfaces, we should know such terms. Anterior teeth, posterior teeth. So anterior teeth, it is canine and incisors. Posterior teeth, it is premolars and molars. So anterior teeth, posterior teeth. As well, we have surfaces of teeth. We have facial surface. We give this name to surface that is close to the cheeks for both posterior and anterior teeth. It is facial surface. But we separate. If it is anterior teeth, we can call it buccal. We can call it, excuse me, labial surface for anterior teeth. For posterior teeth, the same surface we call buccal because close to the cheeks. Surface that is turned to the palate or to the tongue, we call palatal for both anterior and posterior, for maxilla, and for mandible, the same surface will be called lingual. We have cutting edge for anterior group of teeth, cutting edge, that surface that cuts the food, and for posterior group of teeth, we call this surface occlusal surface, a masticatory surface. Here we have imaginary midline. And according to this imaginary midline, every tooth has proximal surface that is close to the midline will be proximal, surface that is far from the imaginary midline will be distal. So every tooth has mesio-proximal surface, disto-proximal surface. Mesio-proximal, disto-proximal. Proximal surfaces, but we call them mesio-proximal, disto-proximal. Every tooth has its special function. Incisors. It is tooth that has one root and the function to cut food. Canine. It is the teeth that have one root and has the function to rip the food. And as well, canine, maxillary canine, holds the angles of the mouth. That's why they give attractive appearance to the lips, to the mouth. Without canines, if they are extracted, the patient's face will be flat, not attractive. So canine holds the lips, the corners of the lips, and that's why the face looks nice. Premolar, it is teeth that have two or one root. They are used to grind and chew food. And molars, teeth with two or three roots, depends from the jawbone. Their function, crushing and mastication of food. Final crushing and mastication of food. After premolar, of course. So initial crushing with premolar, but final sophisticated crushing with molars. As well, the first molar of mandible has the function to keep the height of occlusion. Without patients that do not have first molars of mandible have a very short face, and it looks like the appearance of such patient will be like old person. That's why first molars of mandible keeps the height of occlusion. Morphological differences between primary and permanent teeth. There are numerous differences between the primary and permanent dentition, many of which give rise to considerations in relation to operative treatment. Essentially, primary teeth have shorter crown, lighter color, narrower occlusal surfaces, thinner enamel and dentine, relatively larger pulps, curved roots to accommodate the development of permanent successor. And actually, these are the photo that can give you understanding of how it looks: temporary tooth and permanent tooth. If it goes about description of the teeth, we need to follow certain signs of teeth, criteria that every tooth have in a more pronounced way or less pronounced way. So every tooth has anatomic signs which help clinician to define it to a certain group of teeth. Foremost, they are the shape of the crown, cutting edge or occlusal surface, and amount of roots. The next ones are the signs of belonging of the tooth to the right or left side of jaw. Signs of crown angle, crown curvature, and deviation of root. The sign of the crown angle is a mesial angle of the crown is more sharp than the more obtuse distal angle of the crown. This is especially pronounced for upper central and lateral incisors and for premolars. Sign of the crown convexity is the vestibular side of the tooth is more convex than the lingual aspect. The sign of the root deviation. Deviation of the longitudinal axis of the root from the midline of crowns for incisors and canines in the lateral direction, for premolars and molars in distal direction. To provide successful communication between dentists and better understanding of what is done to what tooth, it was suggested such universal numbering systems. And there are few numbering systems in the world that helps to denote teeth. Universal, it was developed in 1965, most commonly used in the United States. FDI, Federation Dentaire International System, it is mainly used in Canada and European countries. It is easily adapted by computer and is widely used in most countries. And Palmer system. The main idea of universal national numbering system. Numbering of teeth, first of all, oral cavity in this system is not divided into quadrants, and calculation numbering starts from the last molar on the right through the old dentition and to the mandibular and finishing the last molar of the mandibular right. So in this formula, universal numbering system, we have 32 numbers. And do not be confused if you find 29. Okay, so do not be confused. The same calculation for temporarities, but instead of numbers, here it is used letters of starting from A till T. The same clockwise calculation. Okay. FDI, the most preferred and the most widely used, and this is accepted in our country and in most European countries. In this system, oral cavity is divided into quadrants. 1, 2, 3, 4, clockwise direction. Calculation of teeth starts from the central incisor on the maxillary right quadrant, 1, And the first number, it is number of quadrant, second number of tooth. So central incisor will be 11, lateral incisor will be 12, canine 13, first premolar 14, second premolar 15, first molar 16, second molar 17 and 18. And the same for these quadrants. For temporalities, similar idea, but quadrants, we have calculation from 5, 6, 7, 8. That's the same idea. The first number, it is number of the quadrant. Second number, it is number of the tooth. So 51, 52, 53, 54, 55. Palmer system of numbering. We have similar idea. This is divided into quadrants, but instead of number of quadrant, such braces are used. And final statements in our lecture deals with ergonomics. So what is ergonomics? Ergonomics, it is the study of workers and their relationship with the occupational environment. How you position yourself, your patient, how equipment is utilized, how the workplace is designed, and how it impacts your health. So ergonomics, it is a way to work smarter, more efficiently, with less effort as discomfort to the human body. Ergonomics studies and dental health field. People are different. We come in different shapes and sizes, yet the workplace is often set up for one size fits all. People have limitations. We have physical and mental limits for working. The wrist cannot tolerate excessive extension. The back cannot tolerate excessive bending or twisting. The neck was not meant to be in the constant flexion. Muscles will fatigue if under constant tension. Repetitive movements like scaling and polishing accumulate trauma. Vibrations transmitted by dental handpieces or mechanical scalers accumulate trauma. Cumulative trauma add up. These microtraumas cause wear and tear on the muscles, tendons, and nerve tissue. And finally, to finish this lecture, I would like to present this proverb. Where there is a will, there is a way. So if the person determined to do something, we can always find the path or method to do it. The same goes with the students, those who struggle to study. Okay, and references that was used. And as well, I suggest these books at the further reading because you can go deep in some aspects by looking into these books. So oral anatomy, histology, and embryology. Here you can find peculiarities of tooth tissues, dentine, enamel. Dental anatomy, Wolf's dental anatomy. It's anatomy without any words, so structure of the teeth. And dental instruments guide book. And of course, the challenge of the oral diseases. There you can read something deeper about history of medicine and dentistry in particular.